So hello, my name is Philippa. I'm the Macmillan Senior Nurse for Cancer Services here at London North West University Healthcare Trust.
Hello everybody, my name is Koziel. I'm one of the Macmillan colorectal cancer CNSs here at the Trust as well.
So we'd like to thank Neuroendocrine Cancer UK for inviting us to come and do this presentation today. And what we're going to be focusing on is the neuroendocrine cancer patient journey within a local hospital. And we're using the hospital we work at as an example of this. So what are we going to be talking about today? So we're going to talk about why are local hospitals important to you, what the pathways are like for neuroendocrine tumour patients within the local hospitals. And as I say, we'll be using London North West as an example of this. Developments we put in place here to help those pathways and experiences for neuroendocrine tumour patients, and also future developments that we have coming through. So this slide really just highlights, this is a study that was done in 2018, where they looked at how people were diagnosed with neuroendocrine tumours, what were the pathways. And this has really highlighted that 68% of patients were diagnosed via their local hospital. And this was often from a GP, and that was either to come to A&E and be diagnosed through that route, or from a GP to clinic and being diagnosed that way. Also, Bouvier et al., with some unpublished data, has also asked the patients themselves what their experiences have been. And they've highlighted that 53% were initially referred to the local hospital for further investigations via the GP. So that ties in with what we saw in the earlier research. But also it showed that 40% saw a hospital doctor once, 2 times, and 32% 3 to 5 times. So multiple visits to doctors. So there is a lot of work that still needs to be done to improve this experience. And why are local hospitals so important? It's really because we're here. We are your local point of call. So if you are poorly and you see your GP, it is a local hospital you will always go to first. So when we look at some of the pathways, so this is an example of if you came to A&E in your local hospital. Now this is an example of if you've already been diagnosed as neuroendocrine cancer and you're on treatment. So when you come to A&E, all hospitals that have an A&E also have an acute oncology service. And what their role is that when you come to A&E, they will contact acute oncology and let them know you're here. They will come down and see you, review you and your notes, and get more details about your history. And once they're aware that you are under specialist cancer centre and your endocrine specialist cancer unit, they will contact that unit and obtain up-to-date letters and history from the team, and also those really important team contacts. They will then help maintain those links between the local hospital doctors and your specialist team, just to ensure that the care is coordinated as well as possible. And once you're discharged, the acute oncology service will email a copy of that discharge summary to the specialist team, so they're kept up to date. This is more looking now at the diagnosis pathway. So for example, if you are a patient who is at home and has experienced, for example, maybe a swollen abdomen or recurrent ulcers, and you go to your GP, they will refer you into your local hospital, usually under a 2-week wait, for further investigations. Now you may have an endoscopy or an ultrasound, for example, and sometimes those first investigations do show a high suspicion of cancer. They'll be reviewed in the local MDT. Now, depending on the local hospital, some will also have connections to the local cancer centre, and some linked MDTs automatically are happening. And they will help guide those local hospitals at next steps. If at that point they do suspect neuroendocrine cancer, they will also then be referred to the Neuroendocrine Cancer MDT for their opinion as well. They will invite you to a clinic appointment where you'll meet the local consultant, who may be a local gastroenterologist, for example. You'll also meet the local cancer CNS, and you'll be informed of those results and what the recommendations are of those local MDTs. If that MDT has said you need to have a biopsy and it's possible for that biopsy to be happening locally, it will be done locally. And then once that confirmation from histology perspective shows neuroendocrine cancer, you'll go to the Neuroendocrine Cancer MDT for review, and you'll be referred to that specialist centre. And just to be very clear, as soon as any histology confirms neuroendocrine cancer, you go to Neuroendocrine Cancer MDT, which is part of that specialist centre, and be referred to that team. For lung, it's slightly different, so it's just really so you're aware of that. So again, if you have a recurrent cough, for example, and a chest x-ray is organised, and again, you're referred into a chest physician at your local hospital. That investigation will be looked at in the lung MDT, and they may organise a CT at that time. You'll then come to the clinic to discuss the results of that local MDT. Now for lung, sometimes if there's a mass there and they think that that is resectable, removable by surgery, you'll go straight there. And it's when you have that surgery that it shows that that mass that they removed with neuroendocrine cancer. And at that point, you'll be referred to the specialist centre and your care will continue under that specialist centre. If once you've had the, if you go back to when you had the CT, that it's not obviously cancer and they want a bit more detail, then they will organise an EBUS. Now that's an endoscopic investigation into your lungs where they obtain some cells. And again, if that shows neuroendocrine cancer, that will go to the Neuroendocrine Cancer MDT, but you'll be informed of those referrals in advance by coming to a local clinic to be told that, and then the referral process will happen.
So with the pathways for lower GI neuroendocrine tumours, it's a little bit different. Because I don't know if all of you are aware that St. Mark's Hospital is a specialist for a bowel hospital. So we deal with extensive bowel problems, so bowel disease, bowel surgery, and we have really good endoscopy unit as well. So we will most probably see more neuroendocrine cancer from lower origin than other local hospitals. And usually there will be incidental finding via either endoscopy procedure. So for example, if patient was referred for endoscopy, they remove small little polyp that was sent to be tested, and histology shows that it's neuroendocrine. Also from post-op histology, so after the patient had surgery, for example, for removal of appendix, and again, that was sent to be tested and it would come back as neuroendocrine. And sometimes patients will come via A&E, but without the diagnosis of neuroendocrine cancer, they'll present with some abdominal pain, for example, or some symptoms, and they're being investigated and will find neuroendocrine tumor. So therefore, in years 2018-19, we've seen about 15 lower GI neuroendocrine cancers in our service. And then last year that kind of doubled, maybe because we are providing such extensive services for lower GI pathology. So historically, when we found lower GI neuroendocrine tumors, patient will be seen in a colorectal surgical clinic by one of our consultants, and some of this investigation already been done, for example, imaging, or they will have histology sample. And once it's diagnosed, we will then just refer to a specialist center for further investigation and management. So for example, dotatate or gallium scans or chromogranins, things like that. And then that center would manage the patient's journey or pathway. However, because we've seen double figures, really, we started working on a different pathway, just basically to streamline the services and help the patients as well. So now what we're doing, that newly diagnosed neuroendocrine tumors still come to a dedicated lower GI surgical clinic, seen by one consultant who is especially interested in neuroendocrine tumors. One of our nurses, which is in this case me, lower GI cancer CNS, became a link nurse for lower GI NETs, only to provide very similar service that we provide to just our colorectal cancer patients. At the moment, all investigations in diagnostics we can do here on site, so all the imaging, or scans, chromographing, 24-hour urine collection for 5-HIA is also done on site. And since last year, we can request actually gallium dotatate directly from here, from clinic to specialist center. Our link nurse, which is me, again, liaising closely with specialist center and the consultants over there, coordinating the NET-MDT discussions. All surgical and endoscopy management of neuroendocrine tumors. So depending how they've been discussed, whatever MDT decided, we can manage here. So if patient needs surgery, we can do it here. If patient needs, for example, ESD, we can do it here as well. So it saves patient the trip going to a specialist center. And at the moment, we're working on maybe performing some surveillance, imaging and endoscopy to be arranged on site just to save patient the trip as well. Specialist services. So we try to provide specialist services for the patient. So therefore, the CNS became a member of ENETS and UKI-NETS, which helps her in taking part in regular teaching that is offered by ENETS and UKI-NETS. I also have access to Neuroendocrine Cancer UK literature for patients, which is very helpful, especially when we explain the diagnosis. We're closely collaborating with the clinicians and ENETS Specialist Centre in order to provide the best care for the patients. We have regular access to the NET-MDT and its expertise, which is happening on a regular basis every week. So every week, Wednesday morning, the NET-MDT is happening, and then by Thursday, I will receive outcomes. So I know exactly what I need to do for my patients. Also, the gallium dotatate can be requests directly. So the patients need to go and see anybody in specialist center just to arrange a scan. However, we try to help our patients and make the management as smooth as possible. We only have limited services. So for example, we do not have access to lanreotide or sandostatin treatment. So if the patient needs treatment like that, they will be diverted to specialist center. The same if, let's say, a patient had surgery and they need oncology input after the surgery, we won't be providing that. And that will be, again, provided by a specialist center. Also on site, we do not have specialist endocrinology services. And again, patient will be diverted to a specialist center for that. And in the future, what we're hoping to have a dedicated clinic for colorectal neuroendocrine patients, maybe once a week, maybe once in 2 weeks. We still continue improving our communication links between our team and the team at Imperial. Also, we try to educate all the staff, especially the ones that are involved in our patients' care, for example, endoscopy, to know exactly what to do or what to request, what tests to request for our patients. And we would hope in the future to set up a support group for neuroendocrine patients a bit more locally. So that was our dreams. And the research and unpublished data that was done by Neuroendocrine Cancer UK just this year, what you as patients may think that may have your journey to diagnosis better or easier, improved, which was public awareness, easier access to expertise and better communication between healthcare professionals that are involved in care. And I think this is very similar to what we think. So thank you very much for our quick presentation. I will leave you with the last comment from our patient who has been with us for about 2 years now. Thank you very much.